Good afternoon, everybody. We appreciate everyone joining us today. We're very excited to have Tawnya Brock with us today and her expert knowledge on her topic that she is going to discuss with us today about RHC. This webinar is being recorded, and I will be adding it to the IRHA resources for all of our members around the state. Just a few quick housekeeping items before we begin. As I mentioned, we are recording today's session, and it will be available on IRHA's YouTube channel within 1 week once the recording is processed. If at any point during the presentation you want to ask a question, please use the Q&A function. This function is accessible by hovering your mouse over the screen. It should pop up either at the top or bottom of your screen, depending on what view mode you're in. The IRHA staff will keep an eye out for those questions and will moderate for the presenter. That way she does not have to check them during the presentation. So you may begin, Tawnya.
Wonderful. Well, thank you everyone so much for inviting me and having me. And I don't know that I would call myself an expert. I have been doing this for a while, but appreciate sharing just some of the wisdom and knowledge that I've obtained over the years working in a rural health clinic. I am going to go through this fairly fast. This is a big presentation. First time I've actually done it in a webinar like this, so I missed that eye contact because I'm a pretty vocal and verbal person, and I use a lot of hand signals and that kind of thing, so I kind of missed that. I feel like I'm sitting here talking to a computer screen, but anyway, we'll move forward fairly quickly, and hopefully we can entertain any questions that you have. I will not read through every one of these slides because there's just a lot of information I've tried to go through and highlight the main points. So our learning objectives today, what to expect during a survey, what types of deficiencies that you may have. The most common deficiencies that we saw was Quad A for rural health clinic surveys in 2023. And then some processes that you can implement on your own for ongoing compliance. And for me, ongoing compliance is just continuous survey readiness, and it's good quality patient care. Compliance assessment by the surveyor. They're going to address challenges, give you clear citations. They may suggest some corrective actions for you. They will help you to identify best practices. Even above and beyond citations, you always want to be providing the best standard of practice for your patients. Most of your standards are designed for objectivity, so it's either yes, it's there, or no, it's not. So that's pretty simple. Of course, your surveys will always be unbiased, and we hope to provide a consistent survey process. You should see the same with every surveyor. Surveyors talk with your staff, they interview you, open-ended questions, all the same things that we just talked about. They'll ask for documentation to substantiate. I know many of you probably are a part of NARC, and that's one of the things that we teach in that association is your evidence binders. And so you can, however you choose to keep that. A lot of people are on electronic medical records now. They have Policy Tech, NQC, a lot of those different things. So whatever you choose to keep is fine, but you will have to present those to substantiate, your practices. Emergency drills, fire drills, human resource files, those type of things. You'll also have a summation conference. I've often called that, an exit conference. I've been doing this for a while, but, before we leave at the end of the day, you should know any deficiencies that you have, and you can invite anyone to the exit conference that you would like to have participate. Quite often in our smaller rural health clinics, that may only be a clinic manager or maybe a physician, a medical director. In bigger facilities, in our provider-based offices, quite often I'm meeting with, our CEOs, our CNOs, compliance, quality. We may have a whole room full. So we're perfectly comfortable with doing these exit summation conferences, however you feel that you would like to share that information. Again, we're going to suggest corrective practices, share only the facts, helpful tips. We'll discuss all of the citations that you will have, basically trying to create a rapport and a dialogue between us as the accreditation surveyor and you and your facility and staff. Standard level deficiencies. I'm not going to read everything because we won't have time. A standard level deficiency is just that. It is a standard that it means noncompliance exists with one of the standards that make up the conditions for certification, or you guys may have heard that conditions for participation. The survey outcome, the clinic will remain accredited. You will have to submit a plan of correction when you get your statement of deficiencies, and you'll hear those acronyms and SOV. That's your statement of deficiency that comes back to you. The plan of correction is a POC, and that's what you will submit back to us to let us know what you've done to correct your deficiency. And you'll basically tell us how you're going to sustain that compliance. Condition level deficiencies are a little more significant. They are non-compliance with an entire condition for certification. So that may be, if you look at your standards, they will tell you whether they're condition level deficiencies, and there's some that are. One of those that would be condition level is actually having their medical director and having medical staff, their nurse practitioner or PA in your RHC. Condition level deficiency can also be multiple deficiencies at the standard level. So it may be lower level things, but if in one category there are several deficiencies, then that can roll up to a condition level deficiency. For accreditation renewal, an on-site revisit is required when you have condition level deficiencies. They will assess the clinic's correction of the deficiencies that were previously cited. They will reevaluate specific care and services cited during that previous survey. And depending on the nature of the deficiencies, it will dictate the necessity for the scope of the visit. If it's only a few things, when they come back in for that revalidation, they'll focus on just those things. Important note here, because a lot of people that I talk to don't understand that, but for facilities seeking an initial accreditation from Medicare, a condition level deficiency is non-compliance. And so Quad A will not recommend Medicare recertification or certification, and you must go through another initial survey. So again, that would be like a full survey. It's a little different than if you have condition level deficiencies and you're already an RHC. I hope that makes sense. Immediate jeopardy. Very rarely have I ever seen immediate jeopardy in our rural health clinic communities. It is the highest level of deficiency. Immediate jeopardy is a manner of noncompliance that is likely to cause significant injury, harm, or death to a patient. The accreditation outcome, the provider agreement is terminated unless the immediate jeopardy is removed. That's very significant. Hopefully none of us will ever have to go through the process of immediate jeopardy. In 2023, Quad A RHC surveys, everyone is familiar with this. This is your 491 purpose and scope, definitions, certification procedures. These are all the standards that you have to meet when you're applying for certification with the RHC. Top 10 deficiencies for the rural health clinics that Quad A did surveys for throughout 2023. 14G4 maintains a record, and that is all different components of records. That can be the medical history, that can be consent forms, that can be assessment of health status, health care needs of the patients. A lot of things fall out in this area when you're looking at brief discharge instructions, how you the disposition of your patients, instructions to your patients. 14C4, the clinic keeps drugs and biologicals appropriately stored. That's a big one, you know, and lots of times it's out-of-date drugs. I can tell you, I see that quite often, and we still, as much as we all talk about this, guys, believe it or not, those multi-dose vials. 14C4, preventive maintenance program. That's a big one. Lots of times I don't see equipment labeled. 14F10, clinic staff furnishes diagnostic and therapeutic services and supplies commonly furnished in the physician's office. And believe it or not, that's when you're missing medical histories, physical exams, assessments in your treatment records. 14H6, the clinic conducts an evaluation to determine the utilization of services. This is your program evaluation. And quite often I still survey and find program evaluations not completed. 14D5, the clinic has clearly disclosed the name and address of the person principally responsible. You can put that on the door. You can post that, you know, in your front office. You can keep it in your evidence manual, but somewhere that has to be disclosed as who is principally responsible for the direction of the clinic. The premises, 14C5, premises are kept clean and orderly. That speaks for itself. 14D4, the clinic clearly discloses the names and addresses of its owners as well. So that kind of goes hand in hand with D5 up there and D4. And quite often I'll see those together and it's posted, you know, in the entranceway somewhere, or you'll find it, you know, sitting in a picture frame at the registration desk. It's your choice how you do that. 14F8, the clinic provides medical emergency procedures as a first response. We all know what that is. And so you've got to have your emergency kit and have people trained with BLS. 14F13, the RHC provides basic laboratory services. That's your hemoglobin, hematocrit, all those labs that you have to have. We still go in sometimes and find some of those labs missing. Strategies for sustained compliance. These are things that we can share with you, lessons learned over the years that hopefully will help you. Stay organized. Make it a continuous readiness project. I mean, you know, once you figure out what you need to do and you put your processes in place, just do it that way. Don't let things slide for a year or 2 years and then start trying to scramble to get ready for a rural health clinic survey. Figure out what you need to do, develop your processes, do it that way all the time. Take care of your next patient and do it that way. And that way you're focused and you're going to always be continuously ready for a survey. Use your resources, your standards manual, checklist, CMS guidelines, your state laws and regulations. Conduct self-surveys, you know, and survey, you know, if you have peers, you know, or friends that are in another rural health clinic, you know, survey each other. Read your requirements. Make sure, you know, that you're meeting what those requirements are in the manuals. Document how that you're meeting those. Implement plans of corrections for yourself so that you know that you do, and monitor to sustain compliance. That can be your quality and performance improvement programs. Review and update compliance documents. Those documents, and they can be kept anyway. Some people put them in the evidence binder. Some people have them in files. Sometimes they're kept electronically. Your facility license, policies and procedures, reports on how you're demonstrating your compliance, self-audits, any meeting minutes, your biomed inspections, all those things are very important to keep up with. Physical plant and environment, your state posters. All of this is required to be posted. You can choose where you want to post that, but it's for informational purposes for your staff. So, you know, often I'll see this in break rooms. Many rural health clinics that I have surveyed in the past that, you know, they're space challenged and they don't have a lot of room because it's a little small clinic. I'll see these posted in the bathrooms. It's totally up to you, but your OSHA requirements in your state, equal opportunity posters, the Employee Polygraph Protection Act, you can read through all these, FMLA, your labor laws, federal minimum wage posters, all of these things need to be up there. Make sure you have the correct year. That's the other mistake a lot of people. Sometimes this stuff changes. It doesn't, I agree, it doesn't change real often, but you need to check. Sometimes I went into clinics and, you know, their minimum wage poster is from 1980. So you need to update those for sure. Compliance with federal, state, and local laws. The staff of the rural health clinic are licensed and certified. Of course, we know that all of your people need to have your nurse practitioners, PAs. They have to be licensed. All of that information needs to be in your personnel files. Their applications, I-9s, W-4s. Some states require an OIG exclusion. You want to make sure that you've gotten those before they're working and seeing patients. They need to have a signed job description. They need to know what they're responsible for and what your expectations are. And then, when you get that job description, think about competencies in your clinic. I may be a nurse practitioner, but different states have different practice and scope of practice. Different facilities do things differently. So you need to have your competency assessments related back to your job descriptions so that people understand what the expectations are and what it is that they need to do. BLS based on your clinic policies, TB screening based on your state requirements, hepatitis B vaccines, again, for direct patient care and contact. Physical environment of the clinic. The clinic is constructed, arranged, and maintained to ensure access and safety. And we expect the clinic premises to be kept clean and orderly. That's your exit signs. The lit ones are, so that you can see where the exit is. If the electricity or power you have a power outage, you need to be able to find your way out. Your fire extinguishers, your evacuation maps. Think about all those kind of things when you start thinking about physical environment. Cords, that's another big thing. We're all electronic now. Everybody has their computer programs. They have their printers. They've got all the different equipment. And you see what we have here with our slide, that tangled mess of cords. So think about, you see the baby there. You don't want to ever have anything like that. You don't want people tripping over cords if you're having to run cords, over different places. Also think about, in a rural health clinic, you're treating usually people from the cradle to the grave. So you have little people that may be running around there. So you want to think about your outlets and make sure that you have those specific GFCI outlets that people can't get into, or you have the outlet covers, the little ones, or however you choose to do that. But you just have to think about safety of your population of patients that you're seeing. For babies, they may try to chew on a cord, or they may stick something in your outlet. For geriatrics, someone may come over and it's a slip hazard. They could fall very easily. Sharp containers should not be easily accessible to children. They should never overflow, and they also need to be secure. Quite often I go in and you see my sharp container there on the left, and they'll be sitting on a countertop in a treatment room or in a nurse's station, and they're not secured. And when you've got them sitting there like that, and if it's fairly full, and sometimes even if it's not full, it's very easy to turn those things over. And then you've got that biohazard blood exposure and the spill and that type of thing. So secure those. Keep areas under your sinks clear. You can see our pictures right there in your stock rooms and stuff. You don't want to have a bunch of clutter. You want to have things in order and keep them clean and labeled. Oxygen tanks, labeled, full, and empty. You want to keep them secured. There's several methods here. You can attach them to the little rollers and put them up against the wall. You can have the big containers. It just depends on how big your practice is and how much oxygen that you might, have to have on hand. You want to be sure and separate the full and the empty. Organization structure. There are 3 areas that must be addressed and documented when we think about organization structure: basic requirements, written policies, and disclosure of names and addresses. Develop an organizational chart. That's the easiest way to reflect your organization structure, is if you know who your owner is, who your practice manager is, how does that, what is that organizational flow within your facility? Or maybe you're a provider-based clinic and you're part of a huge organization, and you roll up to a vice president and that person rolls up to the CEO. It's totally up to you, but you need to really be able to reflect in your evidence binder or electronically what your lines of authority and responsibilities are. It has to be clearly set forth in writing. The clinic discloses the names and addresses of your owners, the person responsible for the day-to-day direction and operation of the clinic, and the person responsible as your medical director for the medical direction and care given in that clinic. Administrative hours versus clinic hours. That's a big one that we run into still a lot. People don't understand. if you're seeing patients in the clinic, you must always have a physician, medical director, nurse practitioner, or PA in that clinic. You can't have patients in there if you don't have one of those providers in your clinic. You can have it posted administrative hours. If you're going to be open, 9 to 5 to see patients, and you need to have a little bit of administrative time, to maybe answer a question for someone about a bill, something like that, you can do that and come in at 8, and from 8 to 9, look at those kind of things. Those are your administrative hours versus your hours of operation for the rural health clinic. For your hours of operation for the rural health clinic, services have to be provided when one of those approved RHC providers are in your clinic: the mid-level practitioner, social worker, psychologist, or your physician. Biomedical equipment inspection. Of course, the gold standard is your biomed equipment is inspected by a biomedical engineer. That's the best. If you're a part of a provider-based facility and you have a engineering on site, that's probably easy for you. Some of our smaller clinics struggle with that. There's lots of contract agencies that you can reach out to provide that service. I tell you, I saw one small, tiny rural health clinic one time with a nurse practitioner, and her physician was doing her biomed checks. And that would have been perfectly fine had that physician been trained with any biomedical experience to know how to do that. But there was not any training to substantiate his competency to be able to do this. So reach out and find someone to do that for you. Create a preventative maintenance program. And you guys will have to forgive me. I've got a really bad cold today, so I'm having a little bit of time here. But anyway, creative preventative maintenance program. This is just an example that you can look at. Again, lots of times you'll find these electronically now. But you'll list all the different types and just think about all the things that you have in your clinic. You've got your blood pressure monitors, you've got your EKG machines, you may have electronic scales, you may have beds that you're doing, especially in OB/GYN areas that you'll be using. Your dynamats, just think of all otoscopes and ophthalmoscopes, anything that your staff is going to use or that you're going to use in the treatment and care of a patient needs to be looked at. The date you checked it, the action, the name of the person checking it, and when it's due again. Lots of times, and I'll be honest, I love it when people have the little biomed stickers and on the piece of equipment when we do our initial tour of the facility, and it says, biomed checked it, on June 1 of 2023, and it's due again on June 1 of 2024. That's self-explanatory, and we don't have to start digging and looking for that. A lot of people are doing those electronically now that are in the big organizations and provider-based facilities, and that's fine too, but just realize to know when I see just a little barcode sticker on a piece of equipment, we will ask for, that to be substantiated. So you'll have to reach out to someone and try to find out where that log is. All equipment should be listed on an inventory log. Of course, you have your manufacturer's instructions or IFUs. You'll hear that word a lot. That's information for use. And that's basically your manuals and pamphlets that everyone's using to tell you how to take care of that piece of equipment, how to track it when the PMs are due. Annual biomed inspection is evident with stickers, or again, the electronic records like we just talked about. Another sample here just that you can use for equipment inventory count sheets. Medications. Make sure all of your medications are secured, organized, are in date, and that they are in the original containers. This includes all your samples. You have to keep up with those samples just like you do any other medications that you have in your office. Provide education to your staff so that they know the difference between a multi-dose vial and a single dose vial. We've talked about this a lot, but I still walk into clinics and people don't understand the difference between the two. Multi-dose vials, the preference and the standard up there is that we would prefer to have multi-dose vials even dedicated to one patient for one use. But if you're using those multi-dose vials for more than one patient, they have to be kept and accessed in a dedicated area, your medication room, your nurse's station, anywhere away from any treatment areas of patients. I've seen people pick up a medication multi-dose vial, walk out of the nurse's station with it, go into a patient room, puncture the vial, access it, follow through with their procedure or whatever medication, and then bring that multi-dose vial back into the nurse's station. It is then contaminated and is not appropriate for use for anything else. Have documentation that medication dates are checked based on whatever your policy is. Some people do that weekly, some people do it daily, some people do it monthly. It's totally up to you what you create for your policy, but you've got to be checking those medications and make sure that they're rotated, you don't have out of dates in there, and there's lots of different ways to do that. General storage rules, all controlled substances should be stored behind at least 2 differently keyed locks at all times. If you have just the little lock boxes, if you're in these small spaced clinics, do not store the keys near the lock box. Don't store the keys together. And don't leave the keys laying out on the counter at the nurse's station. Have current documentation regarding any ordering and dispensing. You have to do your medication reconciliation. Just like you do medication reconciliation in a patient record, you have to do that for your stock of medication. You need to know what comes into that clinic, how it was dispensed, and maintain that log. Do not keep controlled substances in sample closets, medication refrigerators, or in emergency boxes. They need to be separate in their own container behind those double blocks. Emergency medications. This is always a big question that comes up. The clinic provides medical emergency procedures as a first response to life-threatening injuries and illness, and you maintain the biologicals commonly used. Now, we have a list in our RHC regulations, and I'm sure everyone has seen that, of all these different types of medications. And so everybody gets wrapped up into that. What do I put in my emergency kit? CMS memo, September of 2019. And this is word for word. While each category of drugs and biologicals must be considered, all are not required to be stored. An RHC must have those drugs and biologicals that are necessary to provide its medical emergency procedures to common life-threatening injuries and acute illness. Basically, it's up to you. Your medical director and your medical staff needs to look at what your population is. What do you need to have in there? If you're in an area that you never have any snake bites, I'm in Southeast Tennessee and Kentucky. We have a lot of woods in the spring and summertime. We have copperheads and rattlesnakes out in these mountains. So most everyone will try to not necessarily have snake bite venom in their emergency kit because that stuff is expensive, but they will create a way that they can access that, maybe a relationship with, another hospital or something. But then if you're out in the middle of New York City in the concrete jungle, chances are you may not necessarily need to have an immediate access to snake bite venom. You have to look at what your population is and have the emergency medications available for what you're seeing. Narcan. Do you have a lot of diabetics? Then maybe you want some glucogen in there, those types of things. Infection prevention. OSHA and HIPAA training, PPE is available and accessible. Think about your hand hygiene. I will tell you, yesterday, I was in a conversation with another rural health clinic, and they were a provider-based clinic, and they had encountered Joint Commission surveyors. And we all know washing our hands, before and after procedures and when we're doing patient care. And this particular process had been timed. The recommendation by the CDC is for 20 seconds, and they had only done a hand wash for 16 seconds. So they were short 4 seconds, and there was a citation in that. So think about that. You wouldn't want to have a deficiency because somebody failed to wash for another 4 seconds. So I don't know that I've ever cited anything like that, and I don't know that I would. But different surveyors have different interpretations and backgrounds, so you want to think about that. You could have an infection control nurse that was doing your survey, and they may very well notice those kind of things. When you think about washing your hands, think about happy birthday. If you do happy birthday in your mind as you wash your hands, you probably got it. Clean, dirty segregation in work areas and storage areas. Avoid cross-contamination, clean areas, dirty areas, dirty utility room, clean utility room. In your smaller clinics, sometimes you've got your sink areas and your medications. Put those plastic barriers up so that you can designate this is clean, this is dirty. And also think about anything that is designated for single use. I've seen some single use folks and instruments and stuff out there that people were trying to re-sterilize and use again from a cost efficiency perspective. And you can't do that. Here's your World Health Organization, and there's also some CDC information out there for how to hand wash. Again, infection prevention, you can see the table there with the cracks, in your leather or your vinyl, whatever it is you have. You need to get those things. They just harbor that bacteria when it gets down into the netting. So no cuts or tears. Think about your sandy wipes, whatever it is that you're using in your facility. You need to know what the wet time is, the dry time is. Think about cleaning your high touch surfaces, your doorknobs, blood pressure cuffs, otoscope, ophthalmoscope. Just think about how many times a day that those things are touched. And if you never take the time to wipe them down and clean them, what's sitting out there. That's big stuff. Disposable instruments are best. I would recommend that. I love it when I walk into a clinic and we're not looking at autoclaves and we've got disposable instruments, but sometimes that's not feasible, and you have to do what works for you and your population, to meet the needs of your patients. So follow manufacturer guidelines for instrument sterilization. Pre-clean, wear your PPE, think about puncture and chemical resistant heavy duty gloves. Don't overfill your autoclave. Don't mix wrapped and unwrapped instruments. Don't use packs if they're wet. Think about your biological monitors inside of your packs after you've sterilized them. And those of you who are working with autoclave, I know you're very familiar with this process. You got to have policies about all that. Your weekly spore test, your manufacturer's recommendations for your autoclave, transport contaminated instruments in a puncture and leak-proof receptacle. You also need to have those labeled with those biohazard tags. If you are using an autoclave and you have that, don't be storing things on shelves above your autoclave because that steam escapes and comes up, and then your packages and things up there are getting wet, and so then you have a problem once you have those packages wet with the sterilization and the safety of that. Moving into emergency preparedness, 4 core areas of your emergency preparedness plan. And I still see a lot of problems with emergency preparedness, and it is, I know it's very in-depth and sometimes it is a little difficult to understand, but if you kind of break it up into the different categories, it helps you to know what it is that you need to have out there. Your emergency plan, policies and procedures, you got to have a communication plan, and then the training and testing. You must develop and maintain an emergency preparedness plan that must be reviewed and updated at least every 2 years. Your emergency plan must do all of the following. It has to be based on an all hazards risk assessment. A lot of people are using that Kaiser Permanente. It's a great tool. It helps walk you through the HVA, hazard vulnerability assessment. It will also categorize that for you. And it also continues on and gives you the tabs so that you can document when you're doing your drills, if you have a real event, those kind of things. So it's a very good tool to use to capture the things that you need for your emergency preparedness plan. Needs to include strategies for addressing emergency events identified by that assessment of risk, which is that HVA tool. And so if you're in the Mojave Desert in a little rural health clinic, I wouldn't expect to see flooding necessarily as one of your top 5 things. You may have those occasional, pour down rains that comes and flood, but in general, you have to think about when you're doing that HVA, it needs to be, again, specific to you and your population in the geographic area where you are, and what kind of things that interfere with your operations of your rural health clinic. Address patient population, type of services, think about the things that you can provide in an emergency, and are you going to continue your operations and delegate succession plans, or are you in a situation where you feel like you can't do that? Maybe you're sheltering in place, or maybe you're evacuating and everyone's going home. But those are some of the details that you've got to be looking at. You need to create a process for cooperation and collaboration with outside officials. If you have a huge external disaster or emergency and you have patients in your rural health clinic, or you're evacuating, whichever, you've got to be able to communicate with someone on the outside to know how to follow through and what's going on. Your policies and procedures must include safe evacuation, the place again of your exit signs. Make sure that you think about staff responsibilities and the needs of your patients. When you think about needs of patients, your handicap accessibility, they may not all always be walkies-talkies. So you may have a wheelchair that you're trying to help someone out in, or maybe you're a pediatric clinic and you have little people in there. And so you've got to make sure that they stay with their parent or guardian, or you've got some way to get them safely out if you're evacuating. Indicate a means for how you're sheltering in place. You've got to have a specific place in the clinic for where you're going to shelter in place if you can't get out and evacuate. How are you going to handle your medical documentation? In an emergency, usually you lose your EMR, so you may have to fall back on paper like we did many years ago, but you've got to have some kind of a backup form that you're using that preserves patient information and confidentiality. Address the use of volunteers. They've got to come in quite often in an emergency situation. And so you've got to identify whether you're going to use volunteers or not. That includes processes and roles for the integration of state and federally designated professionals. Just think about surge needs. And if you have the need for those people, or you're going to accept volunteers, then how, address that in your emergency plan. Like your communication plan must include names and contact information for your staff, for entities providing services under contract. Maybe you're contracted next door with an outpatient physical therapy group or something, and they're in your clinic. So you've got anyone that you're having contracts, or maybe you have a contract rotating nurse practitioner there. Somebody's on vacation. You've got to have the same thing for any of the contract staff that you have in your facility that you have for your regular employees. Patients, physicians, any other RHCs, again, your volunteers, and then again, all of those regional and local emergency federal staff, anyone like that you need to be able to reach out to. You've got to have a means of contacting them and a way to communicate. And I just said that your alternate means of communicating. I see that in lots of different ways. Some people fall back on their cell phones. Some people have radios, emergency radios. Some people are on a big provider-based campus, and they say if all that fails, we have a runner, and so it's up to you with what works within your facility or your organization, that you have to have a means to communicate with everyone else, your staff, everyone outside, just in the general condition. You also have to have the ability to communicate the location of your patients, care and providing information about what your needs are. You know, maybe you're sheltering in place with your staff there, and you've got to be able to say, oh, you know, we need water or we need insulin, those kind of things. Training. Develop and maintain an emergency preparedness training and testing program based on your plan and on your risk assessment, your policies and procedures, and your communications. This has got to happen for all your new staff, all your existing staff, all your contract and volunteers. Anyone in your building has to be trained on your emergency preparedness plan. That training must occur at least every 2 years, or anytime you happen to make any significant updates to your plan that things change. Maintain documentation of all your training and competencies. Surveyors will ask for that. So lots of times I see a lot of great activity in the clinic where they've participated with the great shakeout, or they've done, you know, some tabletops, or worked with the local, you know, hospital and done a drill, but they didn't capture anything in documentation, so they can't substantiate that. And it has to be substantiated during your survey. The RHC must conduct exercises to test that emergency plan at least annually. That's an alternate. You kind of think of it as, you know, take and turnabout. Alternate year testing must include one of the following: a second full-scale exercise that is community-based or facility-based every 2 years. Or, so this year, I do a full-scale exercise with my hospital and the community and the EMS and the fire department and everybody. And then next year, okay, we don't want to do a great big thing like that, so we just do a mock disaster drill, you know, just with us and maybe our hospital, or just internally with us. Or maybe we don't even want to do that, go that route and include the hospital. So maybe we just use our staff and we do a tabletop training, you know, right there in our clinic, and talk about what we do. But either way, 1 year full scale, next year something smaller, next year full scale, next year something smaller. You alternate. Facilities must continuously comply with all Quad A accreditation standards and Medicare requirements between their on-site surveys. Surveys are every 36 months for Quad A. Each year we require a self-evaluation. We send out all the information to our clinics. They do a self-evaluation and turn that information back in. Again, if they find things themselves, they're expected to complete that plan of correction, so that brings them back into compliance. And then we ask them to kind of keep a record of that information, because then when we come back in on that third year, in 36 months, I may ask, you know, what were your findings last year, especially if you have a lot of things that seem to be repeating. You know, that's where you want to try to really drill down and provide some education and some help, and collaborate, you know, with everyone, so that we can get a corrective plan in action that is ongoing and continuously compliant. Resources that are available to you: you have your Quad A RHC standards manuals, you've got CMS Appendix Z for your EPP guidance, you've got Appendix G for clinic guidance in your CMS regs, Health and Human Services Public Health Emergency webpage, and I'm going to tell you, that's an excellent webpage. There's a lot of information out there. Waivers and flexibilities, emergency preparedness plan, after action reports. There's just a lot of resources out there available if you get into some of these sites. That's all I have. Questions?
If anybody has any questions, I can open it up so you can speak live instead of typing it in the Q&A.
Well, I certainly appreciate the opportunity, and I've enjoyed talking with everyone, and I hope you have a great spring, and I look forward to possibly seeing you at NARC in a week or so, and hopefully we'll get to see each other again sometime.
Yes, I don't see any questions come through. If anybody does have any questions, they can reach out and we can get back with you with any answers or anything you need. So looks like you've covered your topic perfectly. So if nobody has any questions, we'll go ahead and close the day.
All righty, that sounds great. Thank you so much. You have a great day.
Thank you, everybody. Have a great day.
Bye-bye.